Boundary work and logics of care in the reorganisation of community mental health services in England. I'm Damian Hodgson, and I'm presenting on behalf of myself and my co-authors Abi Taziman and Kate Fryer from the University of Sheffield. Despite increased awareness and increased attention in policy terms, mental health services in England face deeply embedded challenges at the moment. The challenges have a number of causes. They're related to underfunding, general lack of parity with physical health funding, shortages of workforce, and increases demand. These are all factors which have been exacerbated by the pressure of the COVID-19 pandemic. A key challenge in this area is the inadequate provision of support for people with severe mental illness, which includes eating disorders, mental health rehabilitation, and personality disorder diagnoses. Frequently, it is found that people with severe mental illness have needs which are too complex for IAPT, improving access to psychological therapies, but also do not meet thresholds for specialist secondary care. Many of these people continue to be dealt with within primary care and general practice. These challenges were recognised in the NHS long-term plan, which identified an aspiration to develop new and integrated models of primary and community mental health care for adults and older adults with severe mental illnesses. The aim was that by 2023-24, at least 370,000 adults with severe mental illness would receive care from these integrated primary and community mental health services, and some £975 million of funding was set aside to deliver this. This aspiration was operationalised through the Community Mental Health Framework for Adults and Older Adults, which set out a plan to deliver integrated, personalised, place-based and well-coordinated care in the field of mental health. A key part of this plan was to overcome barriers which were perceived to exist between mental health and physical health services, between health, social care, voluntary community and social enterprise, and local communities, and between primary and secondary care. To test out how this might be achieved, 12 early implementer pilots were established across England, and these were set to work through the newly established primary care networks. As these policy documents recognise, to be successful, these initiatives must deliver more integrated care and must overcome systemic barriers between professions and between providers, and must engage much more meaningfully with the voluntary sector. We know from research that integration of care is difficult and that it takes place at different levels, which may include integration at team level, at the service level, at a profession level, or at an organisation level. Other writers have pointed out that integration may take different approaches in terms of their focus and form. So Singer et al. Differentiates structural integration, functional integration, normative integration, interpersonal integration, and process integration. A complementary lens on this process is to see integration as essentially around boundary work. These are strategies used by individuals and collectives to influence the social, symbolic, material, and temporal boundaries, demarcations, and distinctions which affect groups, occupations, and organisations. There are different forms of boundary work, but to take one example, many differentiate between competitive boundary work, which is around laying out boundaries and defending boundaries, and collaborative boundary work, which is about interactions across boundaries and sometimes reducing the impact of boundaries on the ability of individuals and professions to work together. In this presentation, we report findings from an in-depth qualitative study of one CMHF early implementer site, which was testing the implementation of a new service in 4 neighbourhoods of a city of England with above average need for mental health services. This programme involved a range of professions, including psychologists, psychotherapists, community connectors, mental health nurses, health coaches, pharmacists and occupational therapists. And these were employed by primary care providers, mental health trusts and mental health charities. The researchers conducted in total 6 interviews with 62 staff across commissioning, primary care, secondary care and voluntary organisations at all levels. And these interviews covered all direct programme staff, plus 11 service users. The interviews lasted between 30 to 90 minutes and took place between March 2021 and March 2022. They were accompanied by observation and note-taking at key meetings and analysis of documents which were provided to us. Interviews were recorded and transcribed and then analysed using a coding framework. In parallel, notes were reflected upon to develop emergent themes which were observed during the study. Together, a set of themes were derived from this process, and through this we explored instances of boundaries, boundary work, by which we mean activities, negotiations and practices at boundaries or influenced by boundaries, and the existence or influence of logics of care. As anticipated, a range of boundaries were identified which pose challenges to integrated working. These boundaries could be identified as existing between those working in primary and secondary care, between those in healthcare and in other parts of the programme, such as social care and social services, and between health and care and the voluntary sector. We classified these in 2 groups. In some cases, boundary work took place around system boundaries, such as access to IT systems and physical infrastructure. In other cases, these were more process boundaries around the operation of referral and assessment processes, or the how professionals behaved in interprofessional meetings. We should observe from the start that both competitive and collaborative boundary work could be observed, and this reflected one of the overlying questions for the programme as a whole, whether this was seen by participants as an opportunity or a threat. Examples of competitive boundary work typically referred to behaviour where barriers were erected, and these were maybe barriers which were formal in terms of referral processes and how they would be enacted, or practical in terms of simply booking a room. The 2 quotes here point out challenges that were faced in terms of making referrals or simply asking a colleague to print a letter in the system. A key area where this was visible were in the multidisciplinary team meetings, or MDTs, where in some cases we found staff were arguing for barriers that should prevent other groups from participating in the meeting, and this particularly applied to non-clinical staff, such as from the voluntary sector. Various arguments were presented about this in terms of confidentiality and risk, which came down to a deeper question about trust between professionals. At the same time, however, there was also evidence of more collaborative boundary work, efforts to erase such boundaries, and these were typically driven by a shared commitment to flexibility and a sense of a shared purpose within the programme. For some, this was very inspiring, as the first quote points out, about working differently with other services. Others pointed out practical examples of how they've worked collaboratively across these boundaries and across these barriers. Again, the MDT was an interesting and illuminating instance of where this behavior took place. So in other MDTs, there were explanations of how they worked very hard to ensure that a broad team were involved, including voluntary sector and in some cases local authority professionals, and also how an effort was made to make the MDT operate in a more inclusive manner. Understanding why boundary work may take a more competitive or collaborative form was difficult, but they seemed to reflect service pressures, parochial interests, both for organisations and for professionals. More deeply, they reflected different logics of care across the programme, as, for instance, primary care and secondary care had different assumptions and expectations about the incidence of care, caseloads, tolerance of risk, and degrees of autonomy. The two quotes cited here provide examples of this. The question of what is a referral and what is a discharge meant different things in secondary care and primary care. Also, manageable caseloads and what a caseload would mean again differed between primary care and secondary care. It seemed, therefore, that the failure to recognise the existence of other logics of care, or to understand these, drove different forms of boundary work and often presented limits on decision-making, cooperation, and eventually integration. The quotes here present this. They reflect individuals who could see the different logics at play within the system, and to some extent so that there were reasons for each of these logics. These were the first steps towards stepping across those boundaries, as the second quote suggests. Through interaction and through communication, some staff built this stronger understanding of the logics, and this typically generated greater acceptance of differences and more constructive efforts to seek compromise, mutually accepted solutions, and integrated approaches. In summary, then, we see that in mental health and in other areas of health and care, there is a general direction towards greater integration, but to do this demands greater scrutiny of what boundary work means and how it is engaged in. This may require a more refined ability to understand and differentiate forms of boundary work. We mentioned some more complex models here. So Gearin describes boundary work based on expulsion, expansion, and protection. And Zietsma and Lawrence talk about connecting, breaching, and dismantling boundaries. We argue here that a greater understanding of boundary work is essential if we understand not only behaviours but the drivers of these behaviours. And we suggest here that logics of care across sectors, across organisations, across professions may offer insight into the different responses to pressures, and may even explain the incidence of collaborative, competitive, or other forms of boundary work. Thank you for listening to this presentation. If you have any comments or questions, please contact the team directly via the details below. Thank you.